Good evening, friends. It's indeed my proud privilege to be a part of this ISACON 2021, organized by ISACON Kerala State Branch. I profusely thank the organizers of this conference, as well as the office bearers of ISACON Kerala. The given topic to me is desaturation in the immediate post-operative period. And as is well known, there could be many reasons for the desaturation in the post-operative period, immediate post-operative period, and it can be very disconcerting for the patient as well as the anesthetist involved. Therefore, I will try to cover up the topic in about 15 minutes under these headings: introduction, risk factors, clinical features, management, and prevention. And introduction, the respiratory complications are the most common major problem in the immediate post-operative period. And they are second only to post-operative nausea and vomiting. And desaturation and hypoxemia, why are they important, is that it can lead to respiratory arrest, and it's a strong indicator of patient's instability. It also compromises the wound healing and promotes other serious complications like hypoxic brain damage or dysrhythmias and myocardial ischemia. The etiologies are varied, and it can be due to the abnormalities in the upper airway, lower airway, and lung parenchyma. I will try to cover each part of these aspects as we go by, as well as the abnormalities of peripheral nerves and muscles that control the breathing. It's specifically directed towards inadequate reversal of neuromuscular blocking drugs. Why this is important, appropriate monitoring of desaturation is very important, is early diagnosis and timely management can reverse the near fatal respiratory compromise. What are the risk factors? The patient-related risk factors, it can be procedure-related risk factors, and it could be anesthetic risk factors. In a nutshell, the early post-operative hypoxemia or desaturation basically depends on the patient-related factors like obesity, age more than 55 years, history of COPD, history of smoking, and if the patient presents to you with saturation of less than 95%. And the surgical related factors are if the surgical duration is more than 120 minutes, if the incision is upper abdominal, and if there is significant blood loss intraoperatively. The anesthesia related, the major cause could be general anesthetic alone, the inhalational anesthetics, neuraxial opiates, and deep post-anesthetic sedation. They're all could be the causes for early post-operative hypoxemia. We'll look at each one of them in a minute detail. Patient-related risk factors, as I said, are COPD, asthma, if the patient is obese with obstructive sleep apnea, if the patient has already presented with heart failure or pulmonary hypertension, if the patient has upper respiratory tract infection, the patient is used to tobacco, and the metabolic factors like albumin less than 3 grams per deciliter, burn of more than 30 milligrams per deciliter, and of course, the patient presenting with higher ASA risk classes. The procedure-related risk factors could be the surgical site very close to the diaphragm. It could be thoracic or upper abdominal surgery, basically because the pain splints the diaphragm, and then the patient's respiratory efforts may not be the best, and there will be retention of secretions and there will be hypoxemia. The surgery into the airway too can cause upper airway obstruction when the blood and the debris trickle down into the upper airway. Neurosurgical procedures may cause altered mental status with resultant hypoventilation or pulmonary aspiration. The fluid resuscitation with large volumes when liberal volumes of fluids are used, and if the procedure duration is more than 3 hours, can all of them contribute to post-operative hypoxemia. The anesthetic risk factors is basically the patients who receive general anesthesia are more likely to have PPCs than those who had neuraxial or other regional anesthetic techniques. Administration of neuromuscular blocking agents during general anesthesia is again a risk factor, basically because of inadequate reversal at the end of the surgery. And the opiates, intrathecally administered or intravenously administered, can cause respiratory depression early or late in the postoperative period. What are the clinical features of desaturation or hypoxemia in the postoperative period? They vary because of the variety of conditions that may cause respiratory insufficiency in the immediate postoperative setting. The symptoms and signs are not sensitive nor specific. And an awake, extubated patient may complain of difficulty in breathing or hoarseness. However, if the patient is sedated, he may not complain much. Therefore, symptoms may be mild or absent. Tachypnea, when the respiratory rate is more than 30 breaths per minute, is a sign. And shallow respirations and or labored breathing, which is indicated by the nasal flaring, use of accessory respiratory muscles, indicate increased work of breathing and inadequate ventilation. Respiratory arrest failure may occur when the patient is unable to maintain an increased respiratory effort. Bradypnea is another sign when the respiratory rate of is less than 8 per minute, and periods of apnea along with this. It may indicate respiratory depression, basically because of overuse of the opiates or residual effects of other agents used to provide sedation. Saturation less than 93% indicates hypoxemia, and provision of supplemental oxygen may prevent decreased saturation and cyanosis. Thereby, it may delay recognition of hypoventilation. Tachycardia and hypertension are actually secondary to the catecholamine release due to hypoxemia and hypercapnia. And severe hypoxia and hypercapnia with acidosis may result in hypotension, bradycardia, and malignant arrhythmias. It has to be treated much before the acidosis happens. Therefore, early recognition is very, very important. Anxiety, confusion, or agitation. There can be severe somnolence or obtundation. Myoclonus seizures and cardiac arrest are the last signs. We'll talk about each of the aspects which can cause postoperative desaturation or hypoxemia. Start with the upper airway. And the signs of upper airway obstruction are obviously intercostal and suprasternal retractions and uncoordinated abdominal or chest wall motion during inspiration. And if there is complete airway obstruction, it's always silent, whereas the partial obstruction is accompanied by a snoring if it is above the larynx, and inspiratory stridor if the obstruction is perilaryngeal. You have to auscultate the neck and the chest to distinguish stridor from wheeze. Stridor is more prominent over the neck than the chest and is more clearly heard on inspiration than expiration. Coming to the lower airway, you have to auscultate the chest and listen to the wheeze due to restriction of airflow below the level of the trachea. And it's generally caused by the bronchospasm. But there you may not hear any airway, any sounds if there is severe bronchospasm. The chest might be absolutely silent. And if you find a localized wheeze on chest auscultation, it may indicate lower airway obstruction by a mucus plug or a foreign body in the airway. If you hear rales on lung auscultation, it indicates pulmonary edema or atelectasis, and diffuse crackles are a sign of aspiration pneumonitis. And if you auscultate prominent coarse rhonchi, they're due to airway secretions, and you ask the patient to cough or you suck out the secretions, they generally disappear. Depressed levels of consciousness due to opiates or residual anesthetic agents or a neurologic complication may result in hypoventilation with hypercapnia and hypoxemia, which further depresses the consciousness. Therefore, it starts off with depressed level of consciousness. It becomes worse after hypoxemia and hypercapnia ensue. How do you manage the post-operative desaturation or hypoxemia? Initial assessment obviously includes a targeted examination, ABGs and chest X-rays, but obviously you cannot be wasting time doing ABGs and chest radiographs. Therefore, you have to start the patient on oxygen. If needed, urgent airway management and other measures to save the life of the patient. You can look at the risk factors for specific causes as the time goes by. ABGs are performed in patients with suspected respiratory insufficiency immediately to determine the presence and severity of abnormal gas exchange like hypoxemia, hypercapnia, and metabolic abnormalities like metabolic acidosis. If you get a chest X-ray done when the time permits, it will also indicate the causes for hypoxemia like pneumothorax, pulmonary edema, pneumonitis, foreign body airway obstruction, atelectasis, or pneumonia. How do you stabilize the patients? Supplemental oxygen is the only therapy which you can institute immediately. And you can use conventional oxygen delivery systems or non-rebreathing face masks or HFNC at a rate of about 60 liters per minute. If needed, you have to do the bag masking with positive pressure ventilation. Endotracheal intubation or re-intubation and controlled mechanical ventilation may also be needed in some circumstances. Therefore, airway equipment for re-intubation should be immediately available in the PACU. The airway cart has to be ready at all times in the PACU. Surgical support should be available in case you could not secure the airway and then the front of neck access has to be obtained. A surgical team should be available to try out the emergency cricothyrotomy or tracheostomy. NIV is a very good option to maintain saturation in the post-operative period before the need for re-intubation. And NIV should not be delayed till the patient lands up in severe respiratory failure. It has to be instituted very early in the PACU. And if the patient has already been on CPAP preoperatively for his oxygenation needs, maybe with obesity or COPD, it is better that you resume this therapy in the previously prescribed level immediately after the patient reaches the PACU if there are no contraindications. The patients on NIV should be continuously monitored, and every couple of hours the patient has to be reassessed. And if the patients improve with the NIV, you may continue with the NIV in the PACU or another monitored setting like a multidisciplinary intensive care unit. If the patient fails to respond within the first 2 hours, they are re-intubated with the initiation of the mechanical ventilation. NIV is tried for 1 to 2 hours, and if it does not work, you re-intubate and mechanically ventilate after a couple of hours. Whenever you administer oxygen, make sure that it's humidified because the dried and inspissated secretions can cause more obstruction. And if the patient cannot, for any reason, cough and expel secretions, oral or nasotracheal suctioning, they generally clear the tracheal secretions, and it also stimulates the coughing so that patient can clear his airways by himself. Rarely you need flexible fibroscopy, bronchoscopy, to suck the airways, which cannot be reached with suction catheters. And you may also remove the foreign bodies or thick mucus plugs with the flexible bronchoscopes. If there has to be pharyngeal muscular weakness, generally it is caused by the residual effect of long-acting neuromuscular blocking agents. And if the reversal hasn't been timed effectively, the patient can have an upper airway obstruction. The opiates, volatile anesthetics, and other agents with sedative properties contribute to the pharyngeal muscular weakness. And obviously there is obstruction in the supraglottic inlet. And when the patient tries to draw in air, negative pressure generated in the thorax brings the pharyngeal tissues even closer. And then obstruction becomes worse. How do you manage this? Simple maneuvers may be effective. You can try chin lift or jaw thrust. You can also put the patient in the lateral decubitus position and go for oropharyngeal airways or nasopharyngeal airways. If the patient can tolerate an oropharyngeal airway, so be it, he receives it. If the patient cannot tolerate it, put in a nasopharyngeal airway, but carefully insert it so that you avoid a nosebleed. You keep such airway support devices in place till the patient completely recovers from the anesthetics. And occasionally these patients may require reintubation. A few words on laryngospasm, and I'm not going into the depth of the details of laryngospasm. It generally is because of the irritation to the vocal cords due to endotracheal tube removal, secretions, blood or a foreign body in the upper airway. And it can also occur upon cessation of the positive pressure ventilation via face mask. And if there is partial laryngospasm, it allows some air movement, but it may be difficult to distinguish from other causes of upper airway obstruction. If there is complete laryngospasm, it prevents all air movement and may result in severe hypoxemia or negative pressure pulmonary edema. How do you manage laryngospasm? Simple maneuvers such as chin lift and jaw thrust are not effective. And it consists of removing the noxious stimulus. You have to suck out the blood or the secretion, but don't stimulate the glottis much more. Employ positive pressure ventilation with the bag mask with the jaw thrust maneuver. And Larson's maneuver may rapidly reverse the laryngospasm. And in case the laryngospasm is not reversed by all of this, a small dose of succinylcholine, 0.1 milligram per kg IV should be used. And alongside, emergency endotracheal intubation has to be taken up. A few words on airway edema now. The risk factors include the airway or major neck surgery, decreased venous drainage due to prolonged head down or prone positioning, and large volumes of fluid resuscitation. When it's a robotic surgery for prolonged periods of times or laparoscopic surgeries with steep head down position, if the patient presents with facial or scleral edema, generally it indicates that the patient also has airway edema, but it need not be significantly present. And the pharyngeal and laryngeal edema can still be present even when the patient does not have a facial or scleral edema. When the patients have had multiple or traumatic intubation attempts, may also develop edema later. If the patients with airway edema and none of the risk factors are noted above, the causes could be angioedema or anaphylaxis. Angioedema may occur in the perioperative setting due to latex, radiocontrast agents, fibrinolytic agents, calcium channel blockers, opiates, and NSAIDs. And treatment is generally parenteral administration of antihistaminics and corticosteroids, and anaphylaxis is treated with epinephrine. If there has to be a foreign body airway obstruction, you have to, the aspiration obviously causes severe airway obstruction. And if you can do a direct laryngoscopy, you may identify and retrieve the foreign body. Rigid or fiber optic scopy can also be employed. And if you cannot take the foreign body out, extract the foreign body out, if the patient is completely obstructed, you may have to do a front of neck access for airway management. Vocal cord paralysis can occur due to unilateral or bilateral nerve injury, and after the otorlaryngological surgery, thyroidectomy, parathyroidectomy, and rigid bronchoscopy. And point to remember is an inflated endotracheal tube cuff in the subglottic larynx can compress the anterior branch of the recurrent laryngeal nerve between the cricoid and the thyroid cartilage, and it results in the nerve injury. And if the patient has vocal cord paralysis, they generally recover spontaneously over a period of time, a few days to few months. and the resulting increased airway resistance is usually tolerated by the healthy patients, but may create difficulty for patients with pre-existing pulmonary comorbidities. I've mentioned about the lower airway problems which may precipitate hypoxemia, but generally when you auscultate the lungs may reveal generalized wheezing indicating spasm, rales consistent with pulmonary edema, or crackles which may indicate aspiration pneumonitis. Tension pneumothorax, pulmonary embolism, and atelectasis may also cause desaturation in the post-operative period. You should be able to diagnose them, and you have to treat the cause for post-operative desaturation after the general measures. Management includes oxygen, obviously, with antibiotics in case of infection, or aspiration, diuretics for pulmonary edema, nebulization for wheeze, and it goes on. When the neurological status is not so good, if it is because of the sedatives or opiates or inadequate reversal of neuromuscular agents, you have to manage with oxygen, positive pressure ventilation, and if you think naloxone or flumazenil is needed to reverse the effects of narcotics or benzodiazepines, you may use them. Neostigmine, a further dose, or a sugammadex may be used for inadequate reversal. And if the patient has scoline apnea due to pseudocholinesterase deficiency, you manage accordingly, ventilate further, or you go for plasmapheresis. And if the patient has acute neurological event like stroke or seizure, obviously you have to manage them likewise. When do you discharge these patients from the post-operative ward or post-anesthesia care unit? They remain in the PACU until they are no longer at risk of respiratory depression. And the oxygen saturation must be adequate and or recovered to baseline level for at least 15 minutes after the administration of the last IV opiate or sedative dose, or for at least 15 minutes after discontinuation of supplemental oxygen. Then only the patient can be moved to maybe a general bed in the ward. How do you prevent the desaturation, early desaturation in the post-operative period? Preoperative optimization of the comorbidities is mandatory. That is why the pre-anesthetic evaluation holds a major role in the successful outcome of a patient in the post-operative period. Cessation of smoking is mandatory. If the patient is anemic, correct it. Use intraoperatively lung protective ventilation strategies. Never use more than 5 to 7 mils of tidal volume. Appropriate management of the neuromuscular blocking drugs. Time the neuromuscular blocking drugs well so that you can reverse the effects of a neuromuscular blocking drug at the end of the surgery effectively. Protective ventilations, I talked about that. Surgical time should be minimized. Less than 120 minutes is advisable unless it's a major surgery. Post-operative mobilization, chest physiotherapy, and oral hygiene bundle has to be practiced. All this put together, they come under the enhanced recovery protocols. I think early mobilization and physiotherapy go a long way in giving us good post-operative recovery. To conclude, post-operative desaturation is a common complication which requires appropriate monitoring and early diagnosis for its timely management, and then the patient outcome would be much, much better. These are my references, and thank you very much for the patient hearing, and thanks once again for giving me an opportunity.